Adverse effects to cervical spine manipulation. Are they preventable? Let's review yet another study on the adverse effects of cervical spine manipulation. Unlike some previous attempts to paint manipulation as a serious risk unnecessarily taken by patients seeking alternative management, this study attempts to look across a broad time period to determine generally the number of serious events and determine whether these events were preventable, either by using a criteria for appropriateness based on the intended use of the manipulation or from any contraindications or red flags that might suggest a risk for the use of manipulation. As we will see, though, unraveling the logic used to determine appropriateness and attempting to separate out potential causes of adverse effects related to designated risk factors or red flags is a difficult, if not impossible, task. The title of the publication is Safety of Cervical Spine Manipulation. Are adverse events preventable, and are manipulations being performed appropriately? A review of 134 case reports by Puentedura et al., published in JMPT in 2012. The headline from this study would likely read, "Almost half of all serious adverse events with cervical manipulation were preventable," implicitly suggesting that adverse effects are common and that a degree of negligence is at play. Here are the conclusion stats from this study. Let's look, though, at some specifics to see what these percentages actually represent and for whom it may be relevant. The researchers performed a lit search which included the CINAHL database from 1982 to 2010, but included articles published from 1950 to 2010, that's 60 years. Initial search terms included any combination of terms listed here. Also, the researchers conducted a hand search using the reference list from previous review articles on cervical manipulation injuries by DeFabio and Ernst. For those of you unfamiliar with Ernst, he is a vocal, clearly biased medical doctor attempting to discredit all alternative medicine, painting it as not only unnecessary, but life-threatening. To the researchers' credit, they excluded studies if the case report did not report a single event, could not be translated, lacked information for why cervical manipulation was used, or the adverse event was spontaneous without cervical manipulation. So where did the researchers derive the criteria used for appropriateness? Several places, but primarily from a 1995 RAND Corporation review entitled The Appropriateness of Manipulation and Mobilization of the Cervical Spine by Coulter et al. A 9-member multidisciplinary expert panel was presented with a variety of clinical scenarios and asked to rate appropriateness of manipulation or mobilization for each. Here we can see the list of 13 categories that were then published as chapters. The range of case presentations were from simple neck pain, headache, or TMJ pain to more complex cases of radicular pain, neuralgic pain including cranial nerves, and a miscellaneous group including dizziness presentations and cardiovascular conditions, among others. These 13 general categories were used to generate 736 clinical scenarios, of which only 11% were considered appropriate for the use of cervical manipulation. It should be mentioned that the vast majority of these panelists were chiropractors with only a few MDs in the group. The chiropractic group was comprised of an equal number of clinicians versus research-focused chiropractors. Absolute contraindications in the RAND review included this list. Although most are obvious contraindications, many practitioners would argue some latitude clinically for patients with, for example, soft tissue injury, ankylosing spondylitis not involving the cervical spine, or vascular disease, especially if mobilization was utilized, so not all clinicians would necessarily agree with this list. Red flags included a previous diagnosis of vertebral basilar disorder, and all the well-known Ds related to VBI and stroke, if any of these symptoms were aggravated by position or movement of the neck, or if there was no change or worsening of symptoms after multiple manipulations, further manipulation was contraindicated. For this study, the researchers used a composite of studies to determine their own set of criteria for appropriate. Cervical manipulation was appropriate only if used for neck pain, neck stiffness, headache, or cervical radiculopathy. It was considered inappropriate if cervical manipulation was performed for low back pain, otitis media, asthma, non-radicular shoulder pain, or maintenance therapy. Again, practitioners would certainly have some justifiable arguments against some of these, but the researchers were attempting to be literature-based in their list so that demonstrable success in the literature improved the risk-benefit ratio. Applying the study's criteria, 80.6% of all reviewed cervical manipulations were performed for appropriate conditions. Preventability was based on the presence of factors that increase a patient's risk for injury. If contraindications or red flags should have stopped the provider from performing cervical manipulation, the adverse effect was considered preventable. When the patient appeared to be clear of any contraindications or red flags to cervical manipulation, it was considered an unpreventable adverse effect. Of the 134 case reports included, the following adverse effects and percentages were found. Arterial dissection occurred in 37.3% of cases, disc herniation in 18.7% of cases, cerebral vascular accidents in 13.4% of cases, and dislocation or fracture in 6.7% of all cases. According to the study's criteria, adverse side effects were caused by inappropriate use of cervical manipulation in 19% of events. Adverse effects were preventable in 45% of cases, and manipulation was both inappropriate and preventable in 9% of cases. Of the preventable cases, 50% were due to a pre-existing cervical spine condition. For preventable cases, bony pathologies should, according to the study's criteria, have contraindicated manipulation in 70% of cases who demonstrated adverse effects. Vascular pathologies in 13.3% of cases, and for miscellaneous conditions, 16.7% of all cases. And in particular, in cases where a vascular event occurred, continued manipulation after no improvement or increase in symptoms occurred in 24.6% of cases. One problem with this aggregate analysis is it does not clearly match the contraindication to the resulting adverse effect. Grouped together, it's difficult to determine and scientifically impossible to determine through retrospective analysis what would be considered a cause and effect relationship. For example, would a bony pathology be considered a risk or contraindication for treatment due to a concern of vertebral basilar damage, or are they only referring to disc herniation? Not clear here. Of all included cases, they found that 5.2% of cases resulted in death, totaling only 7 cases. Based on this study's criteria, 4 cases were preventable, 1 case was unpreventable, and 2 cases were unknown. 2 of the cases were categorized as preventable because the practitioner continued to perform cervical manipulation when symptoms were worsening. So now let's summarize concepts and results of this study. We're all aware of the many issues regarding the safety of manipulation. However, certainly supported by this study, it is again clear that the occurrence of events, in particular vascular events, is rare. When divided into the millions upon millions of cervical manipulations performed over 60 years, a meager 134 cases of all serious side effects, even if a fraction of actual events, indicates that cervical manipulation is still a remarkably safe procedure. The counterargument used, then, is the value of cervical manipulation when used for specific conditions, in particular, if the natural history indicates improvement over time without intervention, or there is no support for the use of manipulation for a given condition. It would seem that researchers perhaps should have included as much as possible the litigious data. In other words, the insurance data on successfully litigated cases would likely expand the small list of case reports reviewed in this study. To assume that all cases are reported in the literature would be naive. This expansion would be revealing. That being said, the scientific concern would be that successfully litigated cases don't always represent truth. This publication by Haldeman et al. In 2002 reminds us of a common flaw in some of the case reports. There is a bias by medical doctors who tend to associate events to manipulation. The authors make a strong case for referral bias, where for each case of stroke only 1 chiropractor is involved, but on average 3 neurologists are involved because a given neurologist alerts 2 other neurologists of the implied relationship. Most importantly, as revealed through the Cassidy et al. Study and supported by the previously mentioned Haldeman et al. Review, vascular events are likely impossible to detect prior to their occurrence. The best a practitioner can do is screen patients for the first or worst headache or neck pain they have experienced and consider emergency referral in those case presentations. Understanding, though, that the patient is in dissection and this referral may be too little, too late. At least if no manipulation is utilized, the accusation of causation is mitigated. It's also true that this study reaffirms that repeated manipulation after the onset of signs or symptoms of vascular involvement are associated with death, and that immediate emergency transport and triage is requisite in cases of any worrisome signs or symptoms. No management approach is without its risks, so patients must understand the rate of events for that procedure and the proposed benefits for the use of that procedure. Only the patient can then make an informed decision. The practitioner, for their part, must be vigilant in referring patients who appear to be in dissection and consider alternate approaches to treatment when there appears to be risk with the use of manipulation. We can only hope the medical profession also applies this standard to their management of patients where the relative frequency of adverse events, including death, is far higher.